My presentation is on COVID-19 in the United States and how it relates to structural violence. So it first emerged in Wuhan, China in December 2019, which was when the virus was initially identified. The first confirmed case in the United States was announced officially on January 20th of 2020. After this, it began to spread globally at a fairly rapid rate, and in general, the globe was largely prepared for a pandemic of this scale, but surprisingly, it hit much harder in the United States than in other first world countries. So, what is structural violence? It was initially defined by Paul Farmer, who was a medical anthropologist. He developed this term while researching HIV and AIDS to describe the impact of different epidemics when combined with other forces. So the term specifically used in one of the writings was social suffering. Social suffering includes political, economic, institutional, and social forces that exacerbate existing pandemics and health crises. So as in Paul Farmer's writing, it was HIV and AIDS, but it can also include things like influenza, different health pandemics, epidemics of addiction and disease, and in this case, specifically, it includes COVID-19. So how does COVID-19 relate to structural violence? So there is existing structural inequality in the United States, which I believe is fairly obvious to anybody that lives here and has observed it before. This made COVID-19 much worse than it would have been otherwise. So it specifically impacted marginalized groups to a different extent. These areas are unofficially, no longer by law, but unofficially segregated by race and income. Some of this is a holdover from previous eras of actual segregation. This results in a marked difference in case numbers and deaths between white and non-white persons, low-income and high-income persons, and we will see in some cases there is a significant crossover. Low-income and non-white sometimes tend to go together statistically, so you will see a combination. But in general, the United States features a lot of structural inequalities through housing, transportation, employment, access to resources, which will be described in depth later on. Social distancing and protective policies. So stay-at-home orders first began to be implemented in March of 2020. They were not implemented in all states. Officially, it was 42 U.S. states. Initially, it either completely restricted movement and did not allow people to leave their homes or allowed for select groups to travel under strict guidelines. So certain workers were able to leave, people of certain groups were able to leave as needed, but in general, travel was restricted and it was advised that people not leave the house as much as possible. This was primarily to slow the spread of the pandemic at the beginning. It was also to reduce demand on medical facilities through cases and also preventing additional diseases. So this led to business closures. A lot of places could not allow for safe contact with others, such as restaurants and other entertainment facilities, non-essential businesses. And many businesses simply told their employees to work from home. That's when we began to see the boom of things like Zoom and different file sharing services. As mentioned before, there was flexibility for some groups, some essential workers, especially medical personnel. But essential workers did not always include strictly medical. It often included, fast food workers, retail workers, people who were in lower paid positions, often those that did not allow for working at home. So these people were at a disproportionate amount of risk. Social distancing was also more difficult. Social distancing required people to be 6 feet apart, often recommended that they wear masks and face coverings. It's much harder to do this 6 feet apart social distancing due to things such as public transportation, working in a job. If anyone's worked in retail or fast food or one of those positions, you understand it's very difficult. Other people don't always comply with those orders, and it's not very safe for you. Those who lived in crowded housing could not social distance. Even if someone was infected, they may not be able to get away from that family member and put them somewhere else. So it was pretty much impossible for many people to social distance. There is significant research proving that social distancing was in fact much harder to practice among these groups, lower income and such. And in a study by Finch and Finch, workers with lower education were often employed in positions that do not allow them to work from home in any possible way. So it is proven that some groups were much more susceptible to not being able to practice these, so the implementation of them was highly unequal. Unfortunately, practicing of these policies does show a slowing and decrease in cases proven by the CDC. So it is unfortunate. Communities that complied with them saw a 38% decrease in cases, but this was not equal in lower income communities. Those communities with a higher incidence of poverty and more occupation and essential positions, which we will see tends to correlate with lower income rates, and peoples of color, they tend to have less of a decrease from these social distancing guidelines because they are unable to practice them. So economic disparity, there is a clear number of COVID cases, increasing COVID cases in poor counties versus richer ones. There's a lot of reasons for this. Structural factors, as I mentioned before, greater incidence of crowded housing, more use of public transportation, employment issues, so employment in so-called essential positions that are still going to work and unable to work from home, or financial insecurity necessitating that they do have to come into work. They have to continue with their position. They don't want to risk losing their job because they do not have another option. So they have a greater motivation to go into work even when they cannot ensure their safety. They cannot protect themselves from others, so they are in a very vulnerable position. They also have less access to quality health care. These areas, there is a very unequal distribution of supplies and of access to healthcare. We're also seeing that now with vaccines. They're not distributed to the regions that they may need to be as quickly. There also tends to be a correlation, as we will expand on the next slide, between lower income levels and people of color. Statistically, it is shown that there is just a higher amount. Areas, so for example, 50% of non-Hispanic Black Americans living in urban areas which are subject to extreme poverty, they are dealing with these same difficulties and a significantly higher chance of contracting the disease and maybe passing away as a result of it because of the racial pressures that they're facing. So racial disparity, as mentioned, there's a larger percentage of them making up essential workers, proven in just extensive research by Rogers conducted in 2020 that there's just, it is almost, unfortunately, not separable. There really is just an equal amount. There's a larger percentage of COVID deaths versus a percentage of Black residents overall. For example, and in Wisconsin, 36% of COVID-19 deaths were accounted for by non-Hispanic Black people. They only made up 6% of the population of the state as a whole. This disparity, it exists to a different extent per each state, but in general, for each United State, there is a much higher percentage of accountability of Black persons dying of COVID-19 than of the total population. This is partially due to higher employment in essential positions, as mentioned before. The poverty rates among these areas that they tend to occupy, urban populations, this of course is not a rule. In fact, in some communities, social distancing was practiced to a higher extent in populations with greater number of Black persons. But in urban areas with lower income, this tends to be the case. This is also partially due to less distribution of PPE and testing equipment. It is just very clearly unequal in where it is distributed, and in the past medical crises, there has been a similar lack of aid, unfortunately. There was a greater admission to the hospital of people of color, especially Black persons, especially among Medicaid patients in New York. There was significant research done on that. However, later on in the pandemic, there was a lowering of these numbers, and higher income and white people tended to end up in the hospital and die from COVID more often. And this is theorized to be as a result of earlier immunity to the virus due to them catching it earlier and getting time to develop immunity to it. So discussion of theory, essentially, through all of this research, there's a significant connection between race, economic status, employment in urban areas. Those living in urban areas of a lower income tend to face a greater risk of COVID-19, and risks afterwards. A lot of these people living in these urban areas tend to be people of color rather than white people, and tend to have a lower economic status. And as a result, employment is very important to them. They are in a very sensitive position in regards to income, and so they will put up with, unfortunately, very risky situations where they are likely to catch COVID-19 or continue to go to work if they have COVID-19 because they're so reliant on finances. This is a clear disconnect between the nation as a whole, because many people were able to work at home with no issue at all and be financially, more or less financially secure, while these people were forced to go out and work throughout all of it and put their lives at risk for, generally, often unfortunately, inconsequential work such as fast food or retail, things that could have been reduced to a certain extent but were not, which resulted in people being in significant risk. As mentioned before, there was a change in statistics later on. These people that were infected earlier had more time to develop immunity and were actually less accounted for in later waves of the pandemic. There were still a greater impact on them due to just their situation, so even if they made up less of the statistics, they still had less resources to take care of it. They were also maybe less able to test regularly and make sure that they were safe from it. They had less access to proper PPE, so could not prevent it, but in general were less accounted for later on in the pandemic due to this disproportionate amount of infections in the beginning. My curiosity that was not covered in the research as much was the effect of risk-taking behaviors on rates of COVID-19, especially later on. I was curious about how people deciding to ignore these regulations, not due to the factors I mentioned before, where they were essentially forced to for their own well-being. I was curious about people who chose to take vacations, chose to go to theme parks, or travel cross-country, things like that, when it was not necessary and certainly not advised at the time. So I was curious about how these impacted the rates of disease, such as we saw the trend in people of color being less accounted for and white people and people of higher income being accounted for. I'm wondering how much of that is due to these people choosing to go on vacations, choosing to take risks, to attend parties, to willingly not follow the COVID protocols, not wear masks and keep 6 feet apart, when they really had other options and were advised not to do so. I would like to know if that was a significant amount, or if it was just blown out of proportion, or if it seemed to be larger. I remember seeing what I thought a lot of people who were doing that. Some people, they were in safer areas where that might have been viable, but those risks were certainly not advised, not necessary. You could put off your vacation a little bit longer for your own personal safety, but for people who believe that they have the stability to get sick and recover, financial stability, they may not have seen it as great of a risk. So I would like to know if that impacted the number of case rates to a significant extent. So in general, there was a very clearly inadequate response from the United States. They certainly implemented many of these policies to try and prevent and reduce COVID spread to a lesser extent than many other countries of a similar economic standing. We'd call them first world countries maybe, had done. Some other countries, like for example Australia, was very, very strict about implementing these policies and maintaining them for a long time until they saw the cases reduce. But in the United States, we saw a general trend of maybe 2-week spans of time, relaxing the guidelines, and then seeing the cases surge once again, and then having to do the guidelines again. Really, it seemed that economic well-being was prioritized, which caused even greater damage to these groups that are very sensitive to economic change and are very dependent on, making their paycheck, living paycheck to paycheck. They do not have financial security. So this risk-taking impacted these people greater than anybody else. And in general, the whole country. The preventative policies were certainly not applied to the extent that they should have been, I believe. Supplies were not distributed evenly. There was a very significant lack of PPE for a while, personal protective equipment, masks, and sanitizer. I know was very short supply for a while. Gloves, certain supplies like that were prioritized for medical personnel, which is totally understandable, but many non-medical personnel needed this and were not able to access it, or it was being sold for just extraordinarily high prices. Definitely a little ridiculous. In general, the financial insecurity and racial inequality in employment, which existed before, has existed afterwards, will probably unfortunately exist for a while, but when we were all put in a position where our economic situations were very sensitive, they were impacted greater than anybody else and had to choose to sacrifice their own health to continue their daily lives. I mean, not getting your paycheck, that is going to be a certain source of damage for your life. If you don't get a paycheck for a week, you aren't going to be able to eat, you aren't going to be able to pay rent, you can risk being evicted, or you can go into work and hope that you will not catch COVID-19. And so many people had to kind of weigh the very real, definite risks over potential risks, which, again, many people of higher income, maybe primarily white people, did not have to worry about. So my only hope is that the result of this research and that COVID-19 has been sort of thrust into everybody's minds, it is impossible to ignore it, that this research and the very clear difference between who's being impacted by it will create lasting changes. People realize that people are being hit unequally, that there's disease in all these communities all the time, and just now it has expanded between everybody. I mean, you see many people call COVID the great equalizer, which is certainly not accurate, but it has, I believe, humbled some people and made them realize that we are at a greater risk. I mean, even people who were financially sound beforehand struggled a lot during COVID-19. So I believe that maybe there will be some increased empathy and understanding of what is going on, but we can only hope that it did actually cause a significant change in how people see these things.